CT scan of the abdomen. First of all, you should know something about the indications of examination of the abdomen by CT, and they are many. One of the most important indications for CT examination of the abdomen is to assess equivocal imaging finding, like the findings you have seen on barium study, or finding on ultrasound, or findings on plain X-ray. Then you have to verify the lesion. You may perform a CT scan. Then staging of hepatic neoplasms, metastatic workup of extra-abdominal malignancies, diagnosis of abdominal masses, assessment of biliary problems, diagnosis of vascular lesions like aortic aneurysm and so, assessment of post-traumatic complications of blunt abdominal trauma. And to perform the CT examination of the abdomen, you have to give the patient oral contrast. And this oral contrast is known as the gastrographene, and we usually put 15 centimeter of gastrographene mixed with 1.5 liters of water, and let the patient to drink this mixture over 1 or 2 hours, aiming at opacification of the bowel from the stomach to the rectum. And what's the value of this opacification? And you can see here the intestinal loops are filled with the orally introduced contrast material, so that if you look inside the abdomen and you see these bowel loops which are not filled with gastrographene, then you know that this is pathology. This is not normal bowel loops. These are bowel loops infiltrated by lymphoma, and these are the normal bowel loops filled with gastrographene. Also, you may look inside the abdomen and you can clearly say this is an abnormality. This is a mass involving one of the bowel loops, and you may take a biopsy to verify the nature of the mass. This is why we give the patient oral contrast material to opacify the bowel, so that we can separate the normal bowel from the diseased bowel, which will not be opacified by the contrast material. We do not usually give gastrographene in patients with acute abdominal trauma because hemorrhage inside the abdomen is white. Also, gastrographene is white, and we may got some overlap. In cases of acute renal colic, there may be calculi. The calculi are radio-opaque. The gastrographene is radio-opaque, and we may got overlap of the shadows. Gastrographene is also of high osmolarity, and it may produce some dehydration in patients, and in dehydrated patients we do not usually give also gastrographene. Then to perform the CT scan of the abdomen, the patient lies supine on the machine, and we perform this image. And this image is known as the scanogram. The scanogram is just an image for the abdomen in order to say to the computer where to start and where to end. And we usually say to the computer, start from here, which is the level of the diaphragm, and end here, which is the level of the pubic symphysis. Then the computer will ask the operator about the section thickness. Is it 1 centimeter, 2 centimeter, half centimeter, 3 millimeter? What would you like? Then we usually examine the abdomen every 1 centimeter or 10 millimeter scan interval, starting from the diaphragm, ending by the pubic symphysis. Then some parts in the body we would like to have 5 millimeter sections, especially for the small parts in the abdomen, like the pancreas, the suprarenal gland, and the urinary bladder, for example. When you got a scan in the abdomen, a section, you may have one section like this, where you can see the liver on the right side, the spleen on the left side, the stomach filled with contrast material, the aorta, and the inferior vena cava. We usually, after the patient has ingested the oral contrast, we may inject the patient intravenously also with contrast material, which is the urographene or Teribrex or any kind of contrast material used for urography. And in this case, we would like, before to inject the patient with contrast material, if the patient is examined for the liver, we should have sections for the liver before we inject contrast material, and I will say the reason for this, also for the kidney and also for the renal bladder. If the kidney has excreted the injected contrast material, you will got opacification of the pelvic ileal system, which may contain calculi. Then you are not able to identify these calculi unless you have a non-contrast study or a pre-contrast scans. Then we'll talk about what's meant by the triphasic study of the liver, which is one of the most established examination nowadays for assessment of hepatic pathology. In the previous days, we used to have a pre-contrast scans for the liver, then we inject the contrast, then we repeat the scan once more. How can you differentiate between the pre-contrast and the post-contrast? Just to look to the aorta. If you see the aorta with contrast material inside, then you know that the patient is injected with contrast. And here is the aorta is devoid of contrast material. This is a pre-contrast scan. What is the value of obtaining a pre-contrast scan? Look into this liver and you can see a homogeneous liver parenchyma. These are the vessels running throughout the liver. You don't see focal lesions. If you go back to the non-contrast study, you are able to identify many focal lesions in the liver, like this, like this, like this, like this, like this, like this. What happened? Whenever you inject contrast material, the liver take the contrast as well as the focal lesions. Then they are of the same density and you cannot discriminate between both. And that's why we used to obtain a pre-contrast study in order to see some lesions that may be missed after injection of contrast material. And here is an example where you can see that the liver is markedly enlarged. And this is the pre-contrast study. No contrast is seen in the aorta. After injection of contrast, you see the aorta is opaque. Then, what is the difference between this and that? Can you see focal lesions in the liver in the pre-contrast study? You may be able to say, yes, this is one, this is one, this is one. What happened after injection of contrast? You still see some of the lesions in the scan. But look at this scan, which is known as arterial phase. What do we mean by arterial phase? We scanned the liver while the contrast material is in the arteries. How do you know this? That is this arterial phase. Look to the aorta. The aorta is markedly enhanced. And this is the venous phase after the flow of contrast inside the circulation. How do we obtain this arterial phase and the venous phase? Thanks to the new technology, which is known as the multi-detector machines. They are very fast machines. They can scan the contrast material while in the arteries and also while in the veins and later on after that. So we have 3 phases of scanning depending on the flow of contrast. We scan the liver once in the arterial phase and in the venous phase and in the delayed phase. And this, you know, by fact that most of the hepatic lesions are supplied by the hepatic artery. So you have no chance to see the lesions unless you see the contrast material inside the arteries, while the normal liver parenchyma is supplied by the portal vein. Then if you have a CT scan like this with no contrast inside the aorta, and this is the liver which is cirrhotic, and this is the spleen. You don't see focal lesions in the liver. Then you examine the liver in the arterial phase, look to the contrast material in the aorta, and then you see the lesion. Okay? And after passage of contrast to the venous system, this is the venous phase, and the lesion starts to be missed in the liver parenchyma. And the delayed phase, you may have this image and you can see the lesion inside the liver parenchyma. Then, the triphasic study of the liver is the basic study for assessment of hepatic pathology nowadays. If you perform the normal CT scan, which is pre-contrast and post-contrast, you have the chance to miss so many focal lesions in the liver. But we complemented this previously by ultrasound, but nowadays the basic study for the liver is the triphasic study using the multi-detector machines. This triphasic study cannot be performed by the spiral CT or by the standard CT. There should be a multi-detector CT of whatever channel. 4 channel, 8 channel, 16 channel, 32, 64, any channel can perform the triphasic of the study of the liver. Then I go through the normal anatomy of the abdomen, then I mention some of the details about each organ in the abdomen. You see here, these are sections in the upper abdomen, and you can see the liver, you can see the stomach, you can see the aorta, and you can see the spleen. These are the sections in the upper abdomen. Going down, you can still see the liver, you can see the spleen, you can see the aorta, and this is of course the stomach filled by contrast material. Lower down, you can see the spleen and the start of the pancreas. This is the pancreatic tail, and this is the pancreatic body. You don't see the head of the pancreas because it is located lower down. And here you can see the liver, and you can see the spleen, you can see the tail and the body of the pancreas, you can see the aorta and the inferior vena cava, as well as the beginning of the gallbladder. And also here in this section, you can see the start of the left kidney and the start of the right kidney. This is the left kidney, this is the right kidney, this is the aorta, and this is the IVC. And you can see that the aorta is surrounded by 2 structures which represent the diaphragmatic crura. This is the cross, left cross, and this is the right cross of the diaphragm, and this is the diaphragmatic hiatus where the aorta passes into the abdomen. Then you can see here, this is the tail of the pancreas, this is the liver, this is the aorta, this is the IVC, and this is the spleen. You can see the left kidney, you can see the right kidney, the beginning of the right kidney. If you look here, this is the aorta with the 2 crura on either side. And there is a branch coming from the anterior aspect of the aorta. And you know that there are 3 branches coming from the anterior aspect of the aorta. The celiac trunk is very short to be seen in the CT scan. The inferior mesenteric artery is very thin to be seen in the CT scan. Then the only vessel coming from the anterior aspect of the aorta and is seen on the CT scan is the superior mesenteric artery. Then this is the superior mesenteric artery, this is the superior mesenteric artery, this is the liver, this is the gallbladder, and these are intestinal loops. You go more down, then you can see the head of the pancreas. How you know that this is the head of the pancreas? By these 2 very important anatomic landmarks, which are the superior mesenteric artery and the superior mesenteric vein. And you can see this is the head of the pancreas with 2 vascular structures related to its medial aspect. The smaller one is the superior mesenteric artery, and the larger one is the superior mesenteric vein. And you can see part of the duodenum along the lateral aspect of the head, and if you look carefully, you can see a small hypodense structure here, which is the common bile duct. This is the common bile duct, and you see inside the pancreatic head. This is the superior mesenteric artery and superior mesenteric vein, bowel loops, liver, left kidney, right kidney, aorta, and IVC. If you look in this section, you can see a vessel coming from the left kidney crossing the midline in front of the aorta to join the IVC. This is the left renal vein, and this is the right renal vein. This is the head of the pancreas, this is part of the duodenum, this is the gallbladder, and this is the liver. If you go more down, you can easily see the pancreatic head, you can see the intestinal loop. You may ask yourself why these intestinal loops are not filled with contrast material. Because with the development of multi-detector CT machines, we are not giving patients any more contrast material. We sometimes give them, but we usually give them water only. And if the patient drinks water, you get this appearance. Why we do not give gastrographine? Because of the sensitivity of the machine and the high resolution of the images. We can easily identify the bowel loops even without contrast material by the use of these machines. But you can see bowel loops filled with contrast, and sometimes you cannot see, you see bowel loops which are not filled with contrast material. If you go more down, these are the bowel loops. This is the left kidney, this is the right kidney, part of the liver, the spleen has finished, and the pancreatic head identified by the anatomic landmarks. Going lower down, this is the left kidney, right kidney, part of the liver, and the small bowel loops. Going more lower down, you are approaching the pelvis. And here you only see the aorta and the IVC and the bowel loops in the abdomen with fat around the bowel loops. Lower down, you got that the aorta has divided into two common iliac arteries. The IVC is now two common iliac veins, and you have seen 4 vessels here instead of 2 at the level of the iliac crest. Then going down into the abdomen, and you see the iliac vessels on the left side, the iliac vessels on the right side, and this is the psoas muscle, which will attach with the iliacus muscle to form the iliopsoas muscle later on, and these are the gluteal muscles. Going down, you still see the bowel loops, the vessels, no structures up till now, and lower down you see the renal bladder. And if this is the male pelvis, you can see the seminal vesicles, and lower down you can see the prostate. This is the renal bladder, which is filled with urine. And if you inject contrast material, you will see that the bladder is filled with contrast material. This is the prostate. You may say that this patient is injected contrast material, and you can see contrast material in the vessels. Why you don't see contrast material in the renal bladder? That is because the machine is very fast. It can scan the urinary bladder before the contrast is excreted by the kidney to reach the renal bladder. And this is one of the main values of the multi-detector CT. If the pelvis is for a female, then you can see the bowel loops here are filled with contrast material. The patient has contrast material, and if you look to the relation of the uterus to the renal bladder, you will find that the fundus of the uterus is above the renal bladder, while the cervix of the uterus lies between the renal bladder and the rectum. Then this soft tissue density represents the fundus of the uterus, and if you go down, then you see here is the renal bladder, which is filled with contrast material and urine. The contrast is more heavy, is go down, and the structure which is present between the renal bladder and the rectum is the uterine cervix. And here you can see this is the uterine cervix, this is the rectum, and this is the urinary bladder. Then we have screened the abdomen, and we'll go back to say a few words about each organ in the abdomen. Starting first by the liver, and you know from the previous knowledge, this is the spleen, this is the pancreatic tail, this is the pancreatic body, this is the stomach filled with contrast material, and this is the liver. If you draw a line between the inferior vena cava and the gallbladder, then you will divide the liver into 2 lobes, the left lobe and the right lobe. The left lobe is further divided by the fissure for ligamentum teres into 2 segments, the lateral segment, which is away from the liver, and the medial segment, which is near to the rest of the liver. While the right lobe is divided into anterior segment and posterior segment by an imaginary line in this particular area. Okay, if you look to the liver, and you see that the liver is of homogeneous parenchyma. This is the fissure for ligamentum teres, and this is the lateral segment of the left lobe, this is the medial segment of the left lobe, this is the anterior segment of the right lobe, and this is the posterior segment of the right lobe. Then if you look to the liver and you can see a focal lesion like this, you have to discriminate between cystic and the solid focal lesions. This is the appearance of cystic focal lesion in the liver, and this is the appearance of solid focal lesions in the liver. Why this discrimination? Because most of the cystic lesions are benign, while most of the solid lesions are malignant. Then you can easily separate or predict the nature of the lesion from its appearance. Then I ask you, what do you think about these two focal lesions? They are cystic, they are benign. And what about these focal lesions? They are solid, they are malignant. And the differential diagnosis of cystic lesions will include the simple cyst, the diabetic abscess, the hydatid cyst, and the hemangioma, for example. The malignant lesions will include the hepatocellular cholangiocarcinoma, lymphoma, and metastasis. Then, if you look to the liver, and the liver may be involved by diffuse diseases. These are the three common lesions: the fatty liver, the liver cirrhosis, and the storage disease like hemochromatosis and hemosiderosis. How can you diagnose these lesions? The first, the fatty liver. Fat in the liver will decrease the density of the liver. Then you compare the density of the liver, which should be like the density of the spleen. And if you found that the liver density is slightly lower than that of the spleen, you know that this liver contains fat. And sometimes the liver is markedly infiltrated by fat. Then you can see the liver parenchyma is very low compared to the density of the spleen. And this is a slight fatty infiltration. This is more severe fatty infiltration. And if you look to the liver, and you can easily diagnose the cirrhosis because of the shrinkage of the liver, the irregularity of the surface, the coarse architecture, the presence of splenomegaly, sometimes hypertension, portal hypertension, and ascites. So to diagnose storage diseases, you should have a pre-contrast study. And then you compare the density of the liver by the density of the spleen. Both should be of the same density. But if you see now that the density of the liver is much higher than the density of the spleen, then you know something is added to the liver parenchyma, and this is hemochromatosis, hemosiderosis, and the storage disease. Then if you look to the liver, you should not see any bile ducts, because bile ducts are not usually, the normal bile ducts are not usually seen by CT. But if you look to the CT, and you can see multiple hypodense linear shadows, these are dilated biliary radicals. And this is an example of dilated biliary radicals in the liver. You can see multiple linear hypodense shadows throughout the liver parenchyma. Then you know that the patient has biliary obstruction, and you should search for the cause of obstruction, whether it's calculus or neoplastic lesion. Then you see multiple vessels running throughout the liver. What are these vessels? The vessels running through the liver are the hepatic artery branches, the hepatic veins, and the portal venous radicals. Of course, to see the hepatic artery branches, you should have arterial phase. And you look to the aorta, which is very dense, then you know that these fine branches running throughout the liver parenchyma will represent the hepatic artery branches. And to see the hepatic veins, you should look for this section where the inferior vena cava lies in its fossa on the visceral aspect of the liver. And you will see at that time 3 branches entering the inferior vena cava, and these are the hepatic veins. Any section apart from this will contain the biliary, the portal venous radicals. And you can see this is the portal venous radical. And how do you know? Because this level is not the level of the inferior vena cava in the fossa of the visceral aspect. And at this level, you only see the hepatic veins. And other than that, you can see the portal venous radicals. To see the hepatic artery, you should have an arterial phase injection. And this is one of the advantages of the multi-detector CT. You can say to the CT, I would like to see the portal circulation. Then you inject contrast intravenously and reconstruct the images when the contrast material is in the portal circulation. And you will see this is the spleen, this is the splenic vein, and this is the portal vein, and this is the superior mesenteric vein. You know, the splenic and the superior mesenteric form the portal vein, and these are the portal venous radicals inside the liver. These 2 different examples of what is known as CT portography. Nowadays we do not introduce a needle in the side inside the spleen. We inject contrast material. Is now obsolete, this technique. But you say to the machine, I would like to see the portal circulation by what is known as CT portal venography, and you can see this is the splenic vein, this is the superior mesenteric vein, and this is the portal vein and the big thrombus inside the portal vein. Another case where the liver is cirrhotic, the spleen is markedly enlarged, and there are varices, esophageal varices at the site of the gastroesophageal junction. This is the splenic vein, and this is the superior mesenteric vein, and this is the portal vein. These images are easily obtained in seconds by injecting contrast material inside the vein intravenously. Then if you look to the porta hepatis, which is the hilum of the liver, you should see the hepatic artery, the portal vein, and the common bile duct. The hepatic artery is not seen unless you are injecting in the arterial phase. The common bile duct will not be seen unless it is dilated. Then you will see only the portal vein in the porta hepatis. And if you look here, this is the portal vein, and you can see this is the porta hepatis contain. The portal vein is the most prominent anatomic structure in the porta hepatis. And you remember, this is the aorta, this is the crura on the left side, this is the crura on the right side, and this is the IVC. And if you look here, you can see what's look like an inverted Y. This is the suprarenal gland. And this is the left suprarenal gland, which looks like the inverted Y or the figure of 8 in Arabic. And this is the site of the suprarenal gland. Then a few words about the pancreas, and you know that the pancreas lies obliquely in the abdomen. You should see the tail and the body first, then you see the head of the pancreas later on. And this is an example. You can see the tail and the body of the pancreas, but sometimes if you look inside the abdomen, you can see the whole pancreas. And in this particular patient, the pancreas lies horizontally, so that in the section you can see the pancreatic tail, pancreatic body, and the pancreatic head, and the common bile duct if you look carefully. Then this is the pancreas, the pancreatic tail and the body, and you know that the vessel which is running posterior to the pancreas is the splenic vein, and the splenic vein will unite with the superior mesenteric vein to form the portal vein later on. This is the gallbladder, this is the liver, this is the right kidney, this is the left kidney, and this is the suprarenal gland. And you can easily know that this liver is fatty, comparing the density of the liver by the density of the spleen. Sometimes the pancreas in old age is infiltrated by fat. And then if you look to the pancreas, you can see this appearance, which is normal if the patient is above 50. And you know this is the splenic vein, which is running posterior to the pancreatic body and tail. This is the normal pancreas. This is the splenic vein running posterior to the pancreas, and you see the peritoneal fat is clear. But in this patient with acute pancreatitis, you see the pancreas is swollen. You see the fat glands around the pancreas are dirty. They are obliterated by edema and inflammatory granulation tissue. This is an easy diagnosis by CT if you know the appearance, the normal appearance of the pancreas, and the fat glands around the pancreas are clear. This is the aorta surrounded by crura. This is the inferior vena cava, right kidney, left kidney, spleen, liver, gallbladder. Then the anatomy of the pancreas once more. This is the spleen, this is the splenic vein, and this is the body and the tail of the pancreas. Lower down, you can easily see the pancreatic head with the two important anatomic landmarks. These are the superior mesenteric artery and the superior mesenteric vein, and you can see the common bile duct in the pancreatic head. This is the stomach, this is the pyloric canal, and this is the duodenum surrounding the head of the pancreas, and these are multiple bowel loops, aorta, IVC, left kidney, and the right kidney. Then this is the tail of the pancreas, and this is the body of the pancreas, gallbladder, liver, right kidney, left kidney. And look to this arrow pointing to the superior mesenteric vein, and this arrow points to the superior mesenteric artery, which are the anatomic landmarks for this particular area, which is the pancreatic head. And this is part of the duodenum, and you can see some bowel loops filled with contrast material. And here you can see this is the left kidney, this is the left renal vein, this is the pancreatic head surrounded with the two important anatomic landmarks, superior mesenteric artery and the superior mesenteric vein. Also see the bowel loops filled with contrast. This arrow points to the superior mesenteric vein, which shows internal filling defect denoting thrombosis, and you can easily discriminate the superior mesenteric artery, and the vein should be homogeneously enhancing. And if you see filling defect inside inside the vein, you know that this vein is thrombosed, and this explains the presence of marked ascites inside the abdomen. Then here, these arrows points to the head of the pancreas. And the red arrow points to the superior mesenteric artery, the yellow arrow points, the blue arrow points to the superior mesenteric vein. And in both cases, this is the left renal vein, aorta, IVC, pancreatic head, superior mesenteric artery, and the superior mesenteric vein. You can identify easily the pancreatic head inside the whole abdomen where bowel loops are present. This is the site of the suprarenal gland, which is like the inverted Y, and you see the suprarenal gland on both sides. To see clearly the suprarenal glands, the patient should be obese, and let's say he should have adequate retroperitoneal fat. But in absence of this fat, which is black, the suprarenal glands will be missed in the rest of the abdomen. But knowing the anatomic location and the anatomic configuration, you can easily identify. This is the left suprarenal gland, and this is the right suprarenal gland. This is the aorta, IVC, liver, and the spleen. And if you compare the density of the liver by the density of the spleen, you know that this liver is fatty. Then if you go down, you see intestinal loops filled with contrast material, and this is the psoas muscle on either side of the spine, and you see this is the ureter anterior to the psoas muscle, and this is the ureter on the other side. And you see the ureter because the contrast has been excreted by the kidney, so you can see the ureter on both sides anterior to the psoas muscle. Then, using also the facilities of multi-detector CT, this is a patient have a renal mass on the left side, and this is the right kidney, which is normal. We are able now to reconstruct the images like this. This is the coronal reconstruction where you can see the right kidney, and this is the left kidney with the tumor arising from its lower bole. Also, you may obtain what's known as CT renal angiography, and you can see the hypertrophied renal artery and the malignant circulation supplying the tumor in the lower bole. Also, the same rule applies for the kidney. Cystic masses are benign, solid masses are usually malignant. And this is an example of a solid mass in the kidney representing renal cell carcinoma, and these are examples of multiple simple renal cysts, and you can compare the density of the cyst by the density of the tumor. Then this is also one of the advantages of multi-detector CT is to obtain what's known as virtual endoscopy. What's virtual endoscopy? It is a method by which you can go inside the bowel using the CT facilities in a similar way as exact as the endoscope, the real endoscope. How can you perform this? Let's talk about the colon, for example. And first of all, you clean the colon thoroughly from the fecal matter and inject air inside the colon. And after you inject air inside the colon is you take CT sections, and you can see that the colon is distended by air. Then you order the machine to reconstruct the colon in this way, and you see the colonic loops in a way similar to that is obtained in the periminima, so that you have a map to go through. Then you push a button in the machine, which is known as the virtual camera, and the virtual camera will be like this arrow, and you can go inside the loops and to see what's inside, and I will show you some of this just now. This is the periminima, where you can see this is the rectum and the sigmoid, and this arrow points to a polyp in the rectosigmoid junction. You clean the colon and inject air, and you can see the polyp. It is a sessile with ulcer on its top. And to see this with the virtual colonoscopy, and this is the polyp, and this is the ulcer on its top. And after resection, it was a sigmoid cancer with ulceration on its top. Also, this is a pedunculated polyp. You see the pedicle and you see the polyp. and by the after injecting air, you can see the polyp and the pedicle, and this is the road map where we can go by the virtual camera to see this particular lesion, and this is the image obtained by virtual, and you can see this is the pedicle and this is the polyp. Also, this is the case of familial bulbosis examined by virtual colonoscopy, where you can see multiple colonic bulbi like this. Sometimes you can see the colonic diverticuli, and you see the mouth of the diverticuli going through inside the colon, and if you look on the surface of the colon, you can see the diverticular outpouching also by CT. This is just a comparison between the virtual endoscopy and the real endoscopy of a colonic polyp. And this polyp has a pedicle, and this is the polyp, and this is the real endoscope where you can see the polyp and you can see the pedicle. And I will show, I'll try to show you this, this, and I hope it can work. Okay, just a minute.